is with Kentucky EMS for Children, and some work that she has done has been to develop some resources for the EMS professionals. So at this time, we will turn our attention from how EMS professionals can care best for children to how they can care for themselves and the families when there's a really horrible event. So Mary, please take it away.
Thank you, everybody. This is titled Ways to Cope at the Scene of a Child's Death. Next slide. And the goal is to cover some of the issues regarding how you can give the worst news that you can possibly give someone at the scene. Understanding that EMS encounters this probably somewhat infrequently, but certainly it happens, and it's something that's terrible both for the family and for them. Next slide. It will come as no surprise to most of you that EMS is undervalued and overworked. One of the reasons is that EMS originated as a transportation system after the EMS Development Act of 1973. This means that federal healthcare policy traditionally reimburses ambulance services as a transportation benefit and not a patient care service. There is an essential curriculum, but not an advanced degree. And interestingly, it is often not defined as an essential service, despite the fact that we just went through a terrible pandemic, and obviously EMS was very important to the survival of many patients. The professional role is threaded with hazards and a risk of occupational injuries, and many volunteer services and per diem jobs still exist that don't qualify for health benefits. Next slide. The salary has also been kept almost purposefully low because of the previously mentioned reasons. In fact, the national average annual wage of paramedics is about $40,000, according to the Bureau of Labor Statistics, which is far less than the annual average salary for all occupations. When I looked yesterday, Hawaii was the state that paid the highest wage for EMS. Next slide. So consequently, and partly because of the reasons that I've mentioned, the suicide rate of EMS personnel is 5 times greater than the general population, according to research from Eastern Kentucky University. Next slide. This was a survey done in 2015. In the survey, suicide contemplation was defined as the stress a provider undergoes either as a result of a single critical incident that had a significant impact or the accumulation of stress over time. This stress has a strong emotional impact on providers regardless of their years of service. Questions also included if they had ever contemplated suicide or attempted suicide. The orange bars represent the CDC national average, and the blue bars, the EMS provider survey respondents, which you can see were quite high with respect to both those who had contemplated suicide and those who had committed suicide or tried to commit suicide. Next slide. This was a paper published in 2019 that represented vital statistics information from 2009 through 2015. Of the deaths in that state during this time, almost 8,000 were categorized as suicide. The proportion of deaths attributed to suicide among EMTs was 5.2%, which was twice as high as non-EMTs in that state. Next slide. Code Green is a first responder website that is oriented towards mental health advocacy and education. It is devoted to telling the stories of people who either knew someone who committed suicide or someone who tried to commit suicide. Unfortunately, the site is having some technical difficulties right now, but it is a great resource for EMS providers who are feeling blue and need some resources. Next slide. So the rest of this talk is about the delivery of the worst news. Customarily, this is delegated to a physician in an emergency department, but again, we know that some individuals, including children, are dead at the scene. And none of us receive very much education about compassionate care and the delivery of bad news. I always remind people that regardless of how you feel about it, they will remember what you said and how you delivered this message. And if you deliver it compassionately, they will remember it in a kind way, but they will remember it first thing in the morning and last thing at night for months, because this is something that was tragic to them. Next slide. So in 2013, HRSA funded a project for colleagues and myself to develop resources for EMS providers who were exposed to death in the field. This is a targeted issues grant, and whether it was due to death or termination of resuscitation for perceived fatal injuries, this is devoted to trying to not only help the provider with next steps, which isn't something that is traditionally taught, but also guiding them to helping themselves. Next slide. So the project, since its completion, has been housed on the Kentucky Board of EMS website under the Kentucky EMSC banner. You can see where it's highlighted here. I'm pleased to say that due to Dr. Kate Remick's help, it is migrating to the EIIC website, and there are a number of people who are involved in this project, and I'm very grateful that they have not only recognized its importance, but helped us to modify and make it stronger. Next slide. So you can actually go to the EIIC and find some of the resources that are in the Kentucky website right now. And at some point, when we complete the transition, we will likely take it off the Kentucky website, but it will look like this. Next slide. And there are several drop downs that are already there. Each of these resources opens up into a pull down. Next slide. So for example, the first one is what you can do now, and you can see that it will open up to immediately notify the family of your plan, be clear, even if it's uncomfortable, silence is still golden. So each one of these has specific resources. Next slide. There are also a series of videos that are there that were produced by our simulation team at the University of Louisville. So these have already migrated and are there for you and are on both sites. Next slide. What is not there yet, at least not that I could find, are that there were several publications that were directly related to the project and led to the project or were a result of the project. And if you go to the Kentucky website and you see where the PDF is highlighted, you can actually click that, and the publisher has given us permission for you to get a downloadable copy of the entire manuscript. Next slide. There are also a number of other resources on the Kentucky website, including a first responder resource list, several suggested books, resources for families, and a reference list. These are not full PDFs because we could not get permission for most of those, but it's a reference list for educators, EMS providers, medical directors that is a full, I think there's 300 references for content for this project. Next slide. So in the chat, you will see a link that will lead you to the draft of this card, which is based off of our project. We're anxious for your feedback before we finalize it, and I'll just review what we have in draft. If you care to comment, we'd like to hear from you by close of business on Monday. And the three individuals, Ben Lang, who's a pediatric emergency medicine fellow in Austin, Rick Forrest, who's our chaplain at Norton Healthcare, who helped me with the COPE project and has been willing to continue to offer assistance, and then myself are working on finalizing this. So we'd love to hear from you if you have comments. And so on the right, you see the content from the card. It has our logo and then sets the stage for what it will be about. We anticipate this might be a back and front laminated card that you could put in your pocket. To set the scene, you should introduce yourself, find out the names of the family members that are there and also the child's name so that you can be personal about the messaging. Speak softly and slowly so that the individual can understand what you're saying and it can sink in. And it's good to establish what they already know with a simple question like, what happened here? Or what do you think happened here? And just see what they say in terms of the history. Next slide. To guide the family, you should be honest, avoid jargon, use a D words. You have to tell them that their child has died or is dead in a compassionate way. Express sympathy. Sympathy does mean that you feel sorry for them. I'm sure that there's no one who would disagree about that sentiment at this point. Empathy means that you're trying to actually imagine what it would be like to be them. And I think that takes a little while longer. You need to get to know the family member a little bit. Leave room for questions, offer to make calls if they need to call a relative, a pastor. Listen and respect what they say. And then there are several things to do or not to do to cope for yourself. These are much better elicited on the website, but you want to talk to your partner or debrief with other colleagues at the station. Be aware of what activities will help you personally to process. These are going to be different for individuals versus going out and binge eating or drinking alcohol or doing things that are not going to be of value to you. These things affect us, and I think ability to be self-aware that they will affect us and to understand how to make yourself move through the grief that you're feeling because of the family's grief is really important. Next slide. The most important communication from the parents' perspectives are the attitude of the informer, the clarity of the message, the privacy of the conversation, and the ability of the informer to accurately answer the parents' questions at the time. These come from a paper published with Marcia Levittown as the first author. It's quite old. It was published in 2008 in Pediatrics, and it's called Communicating with Children and Families from Everyday Interactions to Skill in Conveying Distressing Information. I certainly recommend it to anybody, especially anyone who's an educator. Next slide. There are some phrases on here that are good words that you can say. This currently says nurse acronym. I think it needs to say provider. But you can say things like, it looks to me like you're very sad. I understand that. Given what happened, I can't imagine how you feel. I can see how much you care or cared for your child. We will stay here with you until X comes, your family comes, the coroner comes. Tell me more about how you're feeling. Next slide. You can also ask about the child. You know, can you tell me a little bit about what Tommy was like? I think sometimes it helps people just to talk about their child. Communicate at their level. If they're sitting, you should sit down. You should not stand up and look down at them. And if it's a coroner's case, which in some cases it might be, you may have some guidelines about whether or not the family can touch the patient or move the patient. But if they do allow the families to be with the patient, you can guide them in touching the patient and explaining what things are or what things were tried. You can offer water, tissues, etc. So I think the last slide is Yes, just to remind you of ways to contact us. The card is intentionally brief, so it will fit on a pocket card. We just want to make sure it's essential content, and it will also be downloadable, and we'll reference the website with a link and a QR code. So thank you for your attention today.